Right, hi there. My name's Patrick. I'm one of the ST3 trainees over here at Doncaster. I'll be doing a presentation on decompensated cirrhosis. Apologies if there's any child noises in the background. So what we're going to cover in this topic today is a little bit about liver physiology and pathophysiology, some of the signs of liver disease and what we mean by the term decompensated cirrhosis. I'm going to talk about what the mortality is in decompensated cirrhosis and why. I'm going to talk about the treatments and the bundles that we use, talk a little bit about hepatorenal and hepatopulmonary syndrome, and then if we've got time at the end, there's a little true-false quiz to take part with as well. First of all, what we won't be covering in this lecture is acute liver failure, a very different beast to decompensated cirrhosis, and that is patients who present with coagulopathy, encephalopathy, and liver failure with no pre-existing cirrhosis in a term of less than 26 weeks. The vast majority of that in this country is paracetamol ODs, and I'd like to compare the two of them as to acute liver failure is your previously well patient who's got COVID and is now on a ventilator. They've gone from very functioning to very poor functioning in a very short space of time. And a decompensated cirrhosis is your patient who's been sat at home with COPD, they've got scarred lungs, and they've just had something that's tipped them over the edge, whether that's an infection or fluid on the lungs, and they're coming in shortness of breath, oxygen requirements, and with a bit of maybe CO2 retention as well. So they're very different in terms of presentation, in terms of treatments, and in terms of the signs and symptoms that you will be picking up on these patients. Decompensated cirrhosis is by definition an acute on chronic liver injury. So if we start just by recovering what a functioning liver does, I like to break this down into 5 key functions, and I'd describe it that it makes 2 things, it breaks 2 things, and it takes 1 thing. So it makes albumin, which is the major intravascular protein that contributes to oncotic pressure in terms of keeping water held within the bloodstream where it's meant to be. It also makes both clotting and anticoagulant factors. So it not only produces clotting factors, which make the clots when you have an injury or start to bleed. It's also very important in making things like antithrombin, which prevents blood clots from forming in the blood as well. So patients with liver disease present with both clotting and bleeding issues. As said, it breaks 2 things. So it breaks down ammonia. Ammonia is obviously a toxin that builds up in your blood. It converts that through into urea, so it can be excreted by the kidneys. And it also breaks down bilirubin. Bilirubin comes from the breakdown of red blood cells in the body. This is taken out of the body, converted into bile acids and urobilinogen, and excreted via the gallbladder into the intestinal tract and also via the kidneys as well. So that makes 2, breaks 2, and it takes 1 thing. It takes all of the blood from the GI system and it filters that back into the main circulation, involved in much metabolism as it passes through. And that is all of the blood that comes from the lower esophageal junction all the way through your intestinal tract to the rectum. It also drains the pancreas and the spleen, along with the stomach and the liver itself. The liver, functioning liver, has many other things that it does, many other jobs, but I wouldn't classify them as the 5 key issues. It is pharmacokinetic. It's involved in the metabolism of medications. It's a big store of sugar for when we need sugar release into the bloodstream. That mostly comes from the liver. It creates complement and other factors which are key to a functioning immune system. And it works very much producing many other hormones as well. Not to go too deep into it, but I've got a hepatic lobule, so a histological slide through the liver, which shows the hepatic artery and portal venous vein. Their circulations mix, come together, and then all that drains through the hepatic veins into the IVC. And just to remember that each liver cell contributes to all these functions. There's no specialization within the liver. So the functioning of the liver depends on how many hepatocytes are there and working along. They're all playing part of the same team. So what do we mean by the term cirrhosis? So cirrhosis is a pathological process that involves hepatocellular inflammation, followed by scarring and nodule formation. The word itself comes from the Greek word kyros, which means tawny or orange. And you can see by the slides on the top, you've got a normal liver on the left, which is lovely, red, smooth, sort of stuff you pick up from the butchers. And the liver on the right is an example of a cirrhotic liver. And you can see that nodule formation, that scarring formation. Often the liver itself will be shrunken in size due to the damage. So it's unusual to find a palpable cirrhotic liver on examination. Within this country, the most common cause for cirrhosis of the liver is alcohol-related liver disease, but that only makes up about 40% of the cirrhotics that are out there in the population. Other things include hepatitis, non-alcoholic fatty liver disease, and then other autoimmune conditions such as PSC and other drug-related liver injuries. But bearing in mind that although alcoholics only make up 40% of the cirrhotic patients, they do present with over 80% of the decompensated cirrhoses in the department. And that's usually due to ongoing liver damage from continued drinking or other health problems. So the vast majority that we see will be those patients with alcoholic liver disease. And cirrhosis affects all of those 5 key functions, and that's how we can pick it up, and it causes findings that you pick up on examination as well. So the liver makes less albumin, which leads to edema and ascites due to the failure to keep that fluid within the intravascular space. It leaks out into the peritonitic compartment, causing ascites, and then peripherally it can cause edema as well. It makes less clotting factors, so they get derangement in the clotting, raised INRs, which leads to an increased risk of bleeding. But even though they have raised INRs, they're at a much higher rate of picking up things like thromboses as well, because of the reduction of anticoagulant factors as well. So it breaks down less of the ammonia, which leads to hepatic encephalopathy, which we'll cover in a second. And also it breaks down less of the bilirubin, which leads to raised bilirubin and deposition in the skin, the sclera, and picked up as being a jaundiced patient on examination. Also causes a lot of itching to the patient. It can't drain the gastric system, the intestinal system well of all its venous blood because there's hypertension in the portal system, and that leads to raised portal venous pressure, formation of varices, most likely at the lower esophageal junction, but you can also get them in other places, such as around the umbilicus and in the rectum as well. And it also leads to a decreased function of the spleen due to backup of blood in the spleen, and that can lead to things like low platelets. The other factors that a cirrhosis might have effect on is they often present with hypoglycemias because of the reduced sugar storage. They can be immunosuppressed to some degree. They're at much higher risk of drug toxicity, and they're at great risk of developing hepatocellular carcinoma in their lifetime, much more than the general population would be. On the little right there is some of the clinical findings that you may find in a patient with chronic liver disease, but I'm sure we can all examine, and we've all seen those in clinical practice as well. So what do we mean by the term compensated or decompensated? A decompensated cirrhosis is a cirrhosis that is going into a loss of the life-sustaining functions. And just to compare again to the COPD analogy, it's not the patient who sat at home, SATs 88 to 92, but happy. It's the patient who's coming in unwell with the increased shortness of breath and oxygen requirements. So that's defined by the Society for the Liver as the presence of these 5 key symptoms. One is the encephalopathy due to raised ammonia. Bear in mind that you can see the grading of encephalopathy that we have on the right there. It's very easy, especially in alcoholic patients, to miss the signs of grade 1 and 2 encephalopathy, which are essentially mild. They can be often mistaken for alcohol intoxication, and it is stuff like slurring speech, poor balance, confusion, which we do often see in these patients. And it's often not until they hit grade 3 or 4 when they start getting, very drowsy, reduced GCSs. At that point, they may have a flapping tremor or asterixis. So we have to keep a very keen eye on trying to pick up these encephalopathics earlier if we are seeing decompensated livers. So any patient with presentation of acute or new ascites, presentation of upper GI bleed and variceal hemorrhage. I've not gone into too much depth into upper GI bleed in this presentation in terms of the presentation and the management, but we all know about hematemesis and melena. I think that will probably be covered in a talk of itself. Any patients with new or worsening jaundice, or any patients that are come in shocked, hypovolemic, or presentation with sepsis. In studies, you can see on the right there that ascites and encephalopathy, along with upper GI bleeds, are the most common presentations for decompensated cirrhosis. So they're the key things to look out for as well. And often we have to look for an underlying trigger to see why this patient is decompensated. Something has happened to make them going from a functioning to a non-functioning liver. So common causes of that are upper GI bleeds. One, because of the effect on the vascular system, it can cause them to go hypovolemic. But also if you're bleeding through into your stomach, that's naturally going to increase the amount of ammonia that is reabsorbed. And patients who come in encephalopathic may be doing so because of the increased ammonia absorption from an upper GI bleed. They can come in with a condition called SBP, or spontaneous bacterial peritonitis, which is what it says on the tin. It's a infection of the peritoneum in an acidic patient that has come not from a leakage of bowel, but due to the raised pressure and edema in the bowel. They can get translocation of gut microbes from their gut into the ascites. It typically presents with fevers, a generalized abdominal pain with no evidence of guarding, and a generally unwell patient. These patients need either peritoneal drainage, they need long-term IV antibiotics, and it's got a fairly high mortality rate if this is presentation as well. They can come with other infections as well, of course, chest infections, urine infections, cellulitis, which have then tipped them over into the arena of decompensation. We talk about alcoholic hepatitis, which is the acute inflammatory phase of the liver, which is may follow a increased alcohol binge or an increase in alcohol intake for a period of time. And that may be treated, one, with alcohol cessation, management withdrawal, but some of these patients may need admission for IV steroid treatment as well for the hepatitis. Portal vein thrombosis is a very key cause of decompensation, again, because of the propensity to clot, and that is just a blockage of the part of the hepatic vein or the portal venous system, and causes a much great increase in the pressure within the portal venous system. It can be drugs, it can be dehydration, if they have vomiting, say. It can be issues with constipation, because if they're not opening the bowels well, they're going to be absorbing much more ammonia through the release of the gut microbes, and that will push them into an encephalopathic position. So why is decompensated cirrhosis important? They have a great mortality, these patients. They have roughly 10 to 20% mortality patient on that admission. And actually, if you line up a decompensated cirrhosis and a STEMI next to each other in the department, the decompensated cirrhosis has much worse outcomes in terms of mortality, both that admission and survival. But obviously, we think about paying a lot more attention to the STEMI as well. We need to make sure that we are getting the right treatment for these patients. Once they presented in a decompensated state, they've got about a 2-year survival. And if you use the Child-Pugh classification on the right-hand side, certainly those with a severe decompensation, which would go into class C, actually have a less than 50% chance of making it through to the end of that year. So these are pretty much end-stage cirrhosis, which may well be approaching an end-of-life situation. We know that the cirrhosis underlying this is irreversible. There's nothing that you can do to turn cirrhotic liver back into well-functioning liver. And typically, if it's a patient who's had ongoing drinking and liver damage, these aren't great candidates for liver transplantation either. Now, there was actually an inquiry because of the very high mortality that we saw in these patients that was conducted in 2013. And they actually found that our care of these patients wasn't great, and less than half of the patients were receiving adequate care. And that was not in Doncaster, but that is a national survey that was carried out. So the thinking being that was our care contributing to the raised mortality in these patients with decompensated cirrhosis. So off the back of that, what was created after 2013 is something that we term the Decompensated Care Bundle. This was created by the British Acute Society of the Liver and the British Society of Gastroenterologists. And it is we've all used care bundles before in the past, but it is a tick box series of things that should be done for these patients within the first 24 hours in order to reduce the mortality and improve the care of these patients. It's generally accepted to be done by a collaboration between the emergency medicine team, the acute medical team, and the gastroenterologists. But I would very much argue that as an ED, we're probably capable of completing the first 6 sessions by ourselves, and the last one we could probably leave to the medics and the gastroenterologists. But it's a give and take. Anything that we can tick off this list is obviously going to help through with the care of this patient. And we're just going to run through the sort of steps of management that these patients need. Hope you can all make it out. If you use it on a phone, it may be a little bit small. Box 1 is investigations that need to be done, which is your routine things. It's doing observations, a set of blood tests as you'd expect. It also adds calcium, phosphate, magnesium onto the bloods, which wouldn't really come on our front door bloods, so they may need adding on at some point. These patients want cultures, dips, and chest x-rays to look for signs of infections. They're probably going to need an ultrasound of their abdomen, which again, that'll probably be done by the acute medical team. Now, any patient who comes in with decompensated cirrhosis and ascites needs to have an acidic tap done, and that can be done regardless of what the clotting is in the patient. I don't know how many of you have done an acidic tap before, but certainly it's by no means a technically difficult procedure. And I'll talk a little bit about that in the following slide. Recording daily alcohol intake is very important, and it's actually one of the things that are done really poorly. And it's just a simple question that we probably would ask, but maybe not document it down in the notes. So there's space there to do that as well. If the patient has a history of alcohol, do the obvious things. We're giving them Pabrinex, and we need to think about symptoms of alcohol withdrawal. Now, these patients may present in alcohol withdrawal, in which case we know how to treat them. It may be that they're acutely intoxicated with alcohol, in which case we wouldn't necessarily start them on benzodiazepines, but we obviously need to be monitoring for those symptoms as they turn up. If they do need treatment and they aren't decompensated, the advice is that we go down with lorazepam rather than chlordiazepam epoxide, which is given intravenously. And that is because chlordiazepam epoxide is a very long-acting medication, whereas lorazepam is much shorter acting, and the metabolism of lorazepam is a lot quicker in cirrhotic patients than of chlordiazepam epoxide. And the dose equivalence is about 1 milligram of lorazepam equals 25 milligrams of chlordiazepam epoxide. So mostly you're going to be giving these patients 0.5 or 1 milligrams of lorazepam in order to manage those symptoms. Very important, because we know these are vulnerable patients, and the last thing that we want to happen is for them to go on to have a seizure. If you're thinking this patient may have an upper GI bleed, they may be septic or hypovolemic, and they're already at risk of brain injury because of their encephalopathy, the last thing you want to be doing is making this patient have another seizure, which could majorly upset them and make them an unstable patient. So staying on top of the CWAR score and monitoring for signs of withdrawal is very vital in these patients as well. Box 3, infections. Are we treating them with antibiotics? What do we think? If they do have an acidic tap, we obviously need to get someone to follow up with the results of that to see if there are any signs of a neutrophilia in the ascites, which is what we're looking for, and then antibiotics as per trust protocol. Just a little word on acidic tap. It can be done, it could be done in ED, but it's typically not something that we would do. The goal is to have it done within the first 6 hours. And you could arguably say that these patients are having lengthy stays here in the department. They're unlikely to be on AMU within 6 hours, given the bed weights that there are at the minute. And a simple procedure which could fast track some of their treatment and management may be of benefits. The only absolute contraindication is patients who've got an acute surgical abdomen, which will be heading to theatre, because if this patient was in intestinal obstruction, you wouldn't want to be blindly sticking needles through into their tummy. There are some relative contraindications, such as low platelets or deranged clotting, DIC, ileus and pregnancy, where you do have to weigh up the risk and benefits. But the rate of complications from an ascitic tap are very low. If the patient does have ascites, you can confirm that with an ultrasound scan probe on their tummy quite easily, and putting a needle into an ascitic abdomen is not going to cause a bowel perforation. The bowels are floating, they're not going to move, and unless they're in clinical bowel obstruction, you're not going to cause any perforations with a green needle. Easiest places to go is in the right iliac fossa, left iliac fossa. It's typically done blind, but you can use ultrasound as well. Patient sat at 45 degrees, the area is sterilized, and it literally is just poking a needle in and sucking out some ascitic fluid and then putting a dressing on at the end. I'll try and put a link at the end to some good clinical videos which will talk you through them, but if you've done it once before, you'll know that it's an easy tap, and it's probably easier than cannulating a patient at the end of the day. That's sent off the cell counts to see if there are any neutrophils in there. We get gram stains and cultures. We check for protein, glucose, albumin, and LDH, as you do with any serous fluid that you send off to the lab. And then if you're suspecting that it's a malignant effusion, then you may send it for cytology to see if there's any cancerous cells in there. Coming back to the bundle, we need to look for these patients to see if they have AKI or acute kidney injury, or whether they're hyponatremic because of dilational fluid overload. We know the rifle criteria which we're looking for, such as your raised and creatinins. And then again, it's the simple management of AKIs. It is suspending diuretics, don't give anything to injure the kidneys further. We want to think about fluid resuscitating these patients, and it advises that we can use 5% HAS, or we can use sodium chloride. On the next slide, I'll cover a little bit about the fluids in decompensated cirrhosis. We need to think about monitoring the input and output charts. We want to monitor the urine output greater than 0.5 mils per kilogram, and it actually says aim for a slightly raised map than you typically would expect. So, and mean arterial pressure of about 80 millimeters mercury, which equates to about a blood pressure of 100/70 if you calculate it out. So maybe a little bit higher than we generally accept with other circumstances. And then we need to get these patients reviewed at 6 hours. Again, my point is that these patients are still going to be in the department at 6 hours. And if you have still given fluids and you're still not correcting any hypovolemia, we need to think about escalating these patients higher up and towards speaking for a critical care review. See if they need any vasopressors or inotropes or any squeeze from that point of view. We need to consider GI bleeding, which I'll cover here briefly. If you're suspecting that they're having hematemesis, or they've got drop in HB, or they have melena on PR examination, they need fluid resuscitating, but they need a cautious fluid resuscitation, accepting a much lower MAP of 65 or a systolic around 90. These patients need terlipressin, start them on 2 milligrams, continue that 4 times a day until confirmed by gastroscopy. Terlipressin is a vasopressin analog, which causes constriction of peripheral veins, but also constriction of the splanchnic system and constriction of those varices, reducing blood loss. Be careful in patients with known ischemic heart disease, because it will cause coronary vasoconstriction as well. These patients need antibiotics, and one of the best things that you can do with upper GI bleeds is to prescribe them some IV antibiotics such as cefuroxime. About a third to a half of these patients will develop post-bleed infections, so covering with antibiotics is shown to have a good effect on the mortality of these patients. And then it's, again, simple things. If they've got deranged clottings, we give them vitamin K and or some FFP. We give them platelets if they need platelets. We give them blood if they need blood. And then these patients need early endoscopies, ideally same-day endoscopies within 12 hours, which we'd be speaking to the usually via the medical reds to try and get them to arrange as soon as they feel fit. So there are some interesting fluid dynamics in patients who have cirrhosis. They do have a raised blood volume in total, and consequently they have a raised cardiac output at baseline as well. But that blood is not usually in the best places, and you get a lot more blood which is within the portal venous system because of the raised pressure, and usually about 8% extra of their total blood volume is essentially not really participating because it's stuck in their portal venous system and in their abdomen. So they have what we call a decreased effective arterial blood volume. So the amount of blood that their body is able to pump around is actually reduced compared to a baseline. They've got a low oncotic pressure secondary to low albumin, which means that fluid will often not stay in the vascular system as we like, and is increased risk of developing peripheral edema. And excessive resuscitation with crystalloids can lead to further dilution of this albumin, obviously through a dilutionary effect, and that can lead to worsening peripheral edema as well. Studies have been performed on whether resuscitation in cirrhotic patients with albumin solution or saline is better. And in the situation where these patients are coming in with sepsis and hypovolemia, one study showed that resuscitation with 5% HAS showed much better reversal of the hypotension, quicker resolution of the lactate, and a lower mortality all in general. We have to bear in mind that HAS has a much longer half-life and it will stay in the blood around 20 days compared to a bag of saline, which will stay in the blood for about 20 minutes. But it does cost, that's about 100 times price per mil as normal saline does. And the general being is that if you are replacing a patient who is hypovolemic, to start with, normal saline is fine, and you can give up to a litre or two of normal saline, but cautiously think about what you're doing after that, and should you be switching over to human albumin if the patient is still shocked? Do you need to be speaking to the critical care team to start them on some vasoconstrictors instead of throwing in more fluid? So in the first place, saline is generally okay, but later on think about other things such as what blood pressure you're targeting, why we're giving these fluids, do we want albumin or do we want some pressure support as well? And the last two boxes is, have we been considering encephalopathy? Is there a precipitant which is increasing the amount of ammonia that's being absorbed from the feces within the bowels, from a bleed? If they're constipated, are they dehydrated or sepsis, which obviously reduce the, will concentrate in the blood because there's less fluid in there. Any patient who is showing signs of encephalopathy, it's really key to get them moving their bowels out and to clear out all those proteins in the bowels to stop it getting absorbed. There's nothing you can do once it is in the system. It's about reducing the amount that goes in, and it's about making sure that it comes out the other end as well. So these patients need to be passing stool at least twice a day. They need oral lactulose or lactulose via NG or lactulose enemas, phosphate enemas, try and get their bowels working. Can you take the car? No, you can get one. You can. Okay. Sorry. Yeah, so these patients need treatment for encephalopathy, which is mostly about increasing the excretion. And if there's clinical doubt in a confused patient, then you can do a CT head, because again, with the bleeding tendencies, they're at higher risk of having a subdural hematoma as well. I'm not sure what clinical doubt entails, but certainly any patient who's had a bump to the head or any history of trauma or has any neurological signs, we need to think about doing a CT head, although it's not mandatory in any patient who comes in with decompensated liver. The 7 box is probably more of interest to the acute medical team, and these patients do need prophylactic dolteparin, irregardless of the clotting factors. If they have deranged INR, they should still see dolteparin, again, because they're at much higher risk of having clots, and it may be a clot that has triggered the decompensation, such as in portal venous thrombosis. And the only reasons why you wouldn't, if the patient's actually bleeding or if they have a low platelets, if they're thrombocytopenic as well, then you would withhold in all of the circumstances that they need dolteparin. And then, like I say, they need a review by a liver specialist, ideally within 24 hours. They do present with many other difficulties within the department, which we've all had experience with and dealing with probably. They can be acutely intoxicated, which makes not only taking a history difficult, it makes finding encephalopathy difficult. It can mask other symptoms. Like we mentioned, they can have alcohol withdrawal syndrome or seizures. They can have very aggressive or disruptive behavior, difficult to manage, high nursing needs. These patients very well likely may want to self-discharge, and my advice would be to be very careful about self-discharging any liver patient, especially one who's decompensated, because it'll be very hard to prove that they had capacity when they're at such high risk of having encephalopathy and disordered brain function. So you really need to think twice about keeping these patients in the department. They have many comorbidities due to their lifestyle and poor self-care. They have social issues. They may be homeless or have very circumspect situations at home. They're at much risk of having coincidental trauma and falls and having injury from those trauma and falls, which may be the initial presentation, and then a decompensated cirrhosis is found off the back of that. So that's the bundle. I would very much recommend the bundle because we do need to improve the management of these patients. They looked at when the bundle was implemented, and this was up in the northeast in Newcastle, I think it was in the Royal Vic and Sunderland hospitals. And they said, is this bundle improving the care of our patient? And if you look at the parameters with the blue in pre-bundle and the orange post-bundle, it certainly meant that a lot more of the boxes were ticked. The patients were getting terlipressin and antibiotics. People were stopping the diuretics. They were getting TAPs quicker. They were getting OGDs quicker. And it also showed that the hospital stay was reduced from an average of 11 days to 8 days post the implementation of the bundle. I don't think there was any significant effect on the mortality of these patients, but I think there is ongoing looking into that, and that will be reviewed at a later date. But you can argue that these patients are getting better care, and if they're getting shorter hospital stays, that's probably a good thing, and supports continued use of the decompensated cirrhosis bundle. So just another couple of topics to cover. If anyone's heard about hepatorenal syndrome, which is a renal failure secondary to altered blood flow in the kidneys in patients with cirrhosis, there's been a bit of an update in the terminology of this, which has happened just last year. We used to separate it into type 1 and type 2 hepatorenal syndrome. And those terms have now been replaced by hepatorenal syndrome AKI type and hepatorenal syndrome non-AKI type, which are your old type 1 and type 2. And it does clear it up a little bit. Hepatorenal syndrome AKI type is just a straightforward AKI that comes in a patient who also has deranged liver function, maybe because they've been hypovolemic or because they've had bleeds. And the treatment is as we would all treat an AKI. It's fluids, it's input-output management, it's the medications, it's blood pressure support if they're needing it. And it's still got greater mortality you would expect in a AKI, about 50% at 30 days. So it is a bad sign in patients, but like I say, 50% are reversible with good medical management. But we need to be thinking about whether this is what used to be called type 2 hepatorenal syndrome, which is now HRS non-AKI type. And this isn't related to your typical AKI. It is due to progressive diuretic resistant ascites, raised pressure within the abdomen. There's dilation of the arterioles within the kidney. And this is sort of a progressive, irreversible condition. And 90% of these patients or greater will die within months of this condition. There's no medical treatments. And unless the patient is considered for renal replacement therapy, dialysis, if they're a transplant candidate, or if they do have a portal venous thrombosis, whether they'd go for a TIPS procedure, which is a transjugular intrahepatic portovenal stent, which is usually done in this region by Leeds, in order to reverse the portal venous thrombosis and raised pressure. Like I said, this is usually a very bad indication with AKIs that aren't responding to treatment. I also thought I'd mention a little bit of hepatopulmonary syndrome. Often these patients will be shortness of breath, and if they are acidic, we often attribute that to splinting of the diaphragm, as in there's too much pressure within the abdomen and the diaphragm can't effectively pull down, and they're essentially using their intercostal muscles to breathe. It may all be that they've got a bit of pulmonary edema as well, but hepatopulmonary syndrome is the condition where they get arterial dilatation because of raised nitrates that are circulating within the lungs. If you think about it, nitrates that are absorbed through your gut, they come through the liver. If the liver isn't able to metabolize them, they go into the hepatic vein, IVC, into the right heart and then straight into the lungs. And the lungs will cause arterial dilatation, and that'll cause reduced, it'll cause perfusion-effusion mismatches. The interesting fact about this is they get platypnea, which means that when they sit up, their breathing gets worse, and when they lie down, their breathing gets better. So it's different to their pulmonary edema syndrome, where it would be the reverse. And that's because when they sat up, actually the perfusion to their upper lobes drops, and it's much more effective at oxygen exchange. And when they lie down, the perfusion obviously increases too high to do effective exchange, and they get a lot more shunting of blood across the pulmonary system. You also find a lot of finger clubbing in these patients. It is very rare, but it is worth thinking about in patients with liver failure and shortness of breath. Unfortunately, again, like a lot of this, there's not a lot of treatment that they can have apart from oxygen therapy, CPAP in the short term. But unless this patient has a liver transplant, then they're going to have long-term respiratory issues with this. Okay, so if that has gone through a little bit quickly, but I thought we'd just cover a few topics with a few true or false questions. So if I give people a couple of minutes, if you just want to have a look at these statements and just a quick note of whether you think they're true or false, and then I'll run through them. So I'll come back at 9:55. So I just need to check that that email's gone through as well. Oh no, I'm sorry, I'm screen sharing. Oh, got nothing now. Has that left everyone's screen now that I've changed tabs? Hang on, let's go back.
It's still there.
It's still there, is it?
Yeah.
Right, I'll just give one more minute on that, and then we'll run through. All right, and if everyone's free just to shout out answers, we'll start with the top one. Hepatic encephalopathy is an easy condition to spot. What do people think, true or false?
False.
False, yeah. So as I mentioned a little bit earlier, it's very easy to miss, especially in the early stages. Very easy to confuse with alcohol intoxication. So next one, decompensated cirrhosis will usually present with deranged LFTs, especially in the transaminases. Do we think true or false?
True.
True. True. So it can do, but often patients with severe cirrhosis don't have a lot of functioning liver cells left to get damaged. And it's very common for patients to present with deranged bilirubins, clottings, jaundice, but because they haven't got that liver function, their AST, ALT may be slightly raised, but it's certainly not going to be shooting up high like an acute liver failure. So it usually will present with some derangement in the LFTs, but it's probably going to be a bit mild. All patients with decompensation should receive dolteparin thromboprophylaxis.
False. False.
False, yeah. So those patients who have low platelets or active bleeding don't. Everyone else should receive thromboprophylaxis. Okay. Fibronex contains vitamin B12 and thiamine.
I think it contains thiamine.
Yes, you're right, Patrick. So it contains thiamine, which is vitamin B1. It contains B2, B3, B6, vitamin C, and glucose. It doesn't actually contain B12, which is commonly assumed to contain. SBP is a relative contraindication to performing an acidic tap.
False.
False, yeah, it's an indication to perform an acidic tap. Cessation of alcohol consumption has no effect on patient mortality.
False.
False,
False.
yeah. So even though the cirrhosis is a irreversible condition, certainly one of the best things you can do is advise these patients strongly to stop drinking, because continued drinking means continued damage and probably increased mortality in the future with more episodes of decompensation. I'm drawing on the screen. Terlipressin causes coronary vasodilatation.
False.
Yeah.
False, yeah. So it causes constriction, yeah. Okay, which is why we need to be careful in those upper GI bleeds who have ischemic heart disease. A patient who presents with confusion and a flapping tremor requires treatment with benzodiazepines.
False.
False. What do they need?
They need
Lactulose, yeah. They need an admission to medicine and they need lactulose as well, because these are signs of encephalopathy rather than withdrawal.
Withdrawal.
Fine. So the final message, sorry if I sped through things. Is there any questions that anyone has on anything or anything they'd like to discuss about decompensated cirrhosis in particular?
Yeah, Patrick, with the variceal bleed and decompensated liver disease, this what we call tranexamic acid, because we have in the last Thursday, we did review these studies, about 13 studies, so it's still a bit confusing because, somebody was saying there's a whole study or something which say that tranexamic acid is, does not work or is not required. But the paper which we reviewed, they definitely indicated that there's a benefit in it by the time to the endoscopy. So what's your thoughts? Or have you looked into it while you're searching for the lecture?
I've looked into it previously. Like I said, I didn't want to go in depth onto upper GI bleeds in this because that's a whole, a whole hour itself that we could talk about that. So I wanted to keep it fairly brief. My priorities when a patient comes in with an upper GI bleed and decompensated would be 1, blood pressure stabilization, terlipressin, antibiotics, and a scope. Yeah, they're the things that are shown to have the greatest effect on mortality. And I think I wouldn't necessarily automatically jump in for tranexamic acid because I don't think that, from what I've seen and the advice that I've had, is that it is a key fundamental part. I think it can be given or not, but would probably be worth addressing in another lecture where we look at the pros and cons of it more in depth. But like I say, it's not one of the things that I think, okay, this has to happen. We need to stabilize the patient. We need to get blood into them. We need to give them antibiotics, terlipressin, and we need to get them scoped as soon as possible. Those are the 5 things I would be focusing on rather than...
with the FFP, what they call fresh frozen plasma as well. Yeah. No, I think I'm asking this question because there are a bit of uncertainty and different practices and, giving tranexamic. I agree with you because we need to do something else, apart from just jumping on tranexamic acid, because we have seen it's being used a lot in our department. Excellent. Thank you very much.
Okay. Anyone else? In order to get the bundle, I'll speak with the appropriate people about getting it added onto my ED. But if you are seeing a decompensated liver patient, all you need to do is Google decompensated cirrhosis bundle, and it is always the first thing that pops up under BASL. If you can print it out, stick it in the notes and start ticking off those boxes, the acute medical team will automatically think you're their favorite doctor. But if there's one key message that I would advise you to take from this is, in patients with worsening liver failure on cirrhosis, is that if you can please start them on this bundle and then we can get them timely treatments. And there's a link to it on this slide that I can send around.
This, Patrick, is Firas who will put this bundle on my ED.
I'll speak to Firas about it then.
No, it's a very good. I think we should be doing. Yeah. Because the management gut easy is a tick box, and in research situation, people do tend to forget doing stuff.
Yeah, and there's a lot of things to do on there as well. So it's easy to forget things like giving them the lactulose or giving them the Pabrinex, but when you've got it in front of you in paper, it takes the thinking out of it.
Yeah, I think the acetic tap, I know it's a needle putting in the abdomen, but it's very safe. I mean, as you are saying, even a green needle, go in the bowel, there's no consequence at all, so bowel won't be perforated by a green needle. So I think acetic tap, nobody should be scared to do it. It's just at the McBurney's area, just clean and, put a needle in and draw fluid and send to the lab.
And yeah, it's still customary to leave that to the acute medical team, but my point would be that I think we would be more than capable as emergency physicians of taking an acetic tap, but it's just not practice in most departments.
I think given the fact that these skills are taught when you're doing ITU rotation, we should be able to be competent enough, because other departments will be just saying, what is A&E for if they're calling us to do acetic taps and all that kind of thing. It's just, yeah, it puts us in good standing, like what Aftab is saying.
No, there are certain procedures which are not dangerous really, so we should not hesitate to do it. I think it was a very good set of talk, and it was logical, and one thing led to another thing. I think the good presentation, and the first thing which you started, it makes two things, break two things, take one thing. This all talk flow to these 2, 5, 6 points right to the end. I think was very easy. And I think, I remember everything now. I can talk without any aid because it was so logical and systematic, really. I think it was a nice presentation. Well done, Patrick.
All right, thank you.
Thank you, Patrick.
Musami's arrived, I see.
Yeah.
Yes, sir.
Okay, I'm going to have to...
Yeah, I'm going to stop recording now.